today. We got a few things we're going to get through. We'll have some director and staff updates from Annalise and Will and any of the other ADPC staff that are here today. We'll go through the final recovery community center definition. We'll have a little conversation about what are we going to do with this definition once it is codified here, and then we'll have a report from Sharma Lee from the Office in Recovery and Resilience, and I think that's just sort of an introduction to the office and kind of what they do at the state in case.
Yep. Yeah. Still there? Tony, I think you went on mute.
Oh yeah, the host muted me. It said, not sure which one of you guys that was.
We lost you at introducing Charmely.
Oh, so yeah, so I have OHA coming. I'll have Sharma Lee from the Office of Recovery and Resilience to give us an update on, I think, what their department does and an overview in case people are not familiar with what they do. And then we'll have public comment. Before we get started, just a couple reminders. It is recorded, and we reserve public comment for the end of the meeting. So if you're here from the public and not a commission subcommittee member, please hold your comments till then. Feel free to drop them in the chat, and we'll make sure we get to you. And we'll pass it over to you for roll call.
Cool. I'm going to start recording. I'm
already recording the meeting, Will.
Oh, okay. Double recorded. Excellent. Did it mess anything up that I hit record, or you good? Okay. Sounds good. All right. So, Jared. I think I saw Jared. John.
Here.
Frank.
I'm here.
Steve, Cameron.
Here.
Amanda.
Here.
Steve.
Here.
I think I saw Todd.
Here.
Thanks, Todd. Steph Castaneda. Steve. Stephanie, Maxwell Stephanie.
Here.
Ed. Tony.
Here.
And Steph M. And I think I saw stuff. Okay. And yeah, if we were to vote on anything, we have enough people to do that.
Cool. Thanks, Will. Annalise, would you like to start us off with some director updates?
Sure. Thanks, Tony. Annalise Dolph. I'm the director at the Alcohol and Drug Policy Commission. I've been in one meeting after another today. So Will and Tony, if there's anything I forget, please remind me. The commission met earlier this month, just a few weeks ago. It seems like a month ago. And for the most part, heard from OHA about the Rural Health Transformation Program and what the rollout of that looks like. Next month in April, we meet the second Monday of every month. We are going to have our first quarterly update for the 26-2030 comprehensive plan, which is very exciting. We had our quarterly meeting with the state agencies yesterday, and we are really rolling along with quite a few things on the plan, to the overwhelm of the ADPC staff. But that's going along well. So we'll have some more information about that soon. The last newsletter did cover some early wins, which is pretty exciting. The Opioid Settlement Board, always trying to give some updates there, meets the first Wednesday in April. We started talking this month about how to allocate the remaining funding for this biennium. It is the group seems to be leaning towards investing across the continuum of care again, but perhaps a little bit more flexibly, and doing a broader request for proposals, but we'll know more after April. So stay tuned there. And the other committees are rolling along. I think my last announcement, and I'm again, flag for me if I'm forgetting anything, is to introduce our new staff who you've already seen, Ashley Olson. We're so excited to have Ashley on board as our new executive support specialist, and I'd love to give her just a minute to say hi.
Hi, everybody. Can you hear me okay? Great. Hi, I'm Ashley. I'm just wrapping up my first month here at the ADPC. I have been with the state for 2 years, so take it easy on me. I'm still learning. I live down here in Eugene, Oregon. I went to the University of Oregon and got a Bachelor of Science in Psychology. So I come to this work with a very trauma-informed lens. So far, I've been loving it. It's been really great to get to know everybody, to get to know the commission and the committee's work. Let's see what else. Oh, and I'm here to support you. So any way that I can help you, help the committee, just let me know. I am really happy to be here. Yeah, thank you.
Thanks, Ashley. Ashley's bringing our game up. We're so excited to have her. There will be really cool organized meeting notes for all of our meetings going forward. And she's keeping us in line. So we're really excited to have her. I think that is everything that I have. If I forgot anything or if anybody has any questions, feel free to let me know.
Cool. Thank you, Annalise. So the first part of our agenda today, we're going to finalize our Recovery Community Center definition. And just real quickly for anybody that maybe is the first time on the call here, the ADPC broadly sort of oversees recommendations for state agencies related to substance misuse and substance use. We have broken the commission up into four committees. One is primary prevention, one is treatment, one is recovery, and then we have a harm reduction committee as well, which is going to be having a new name here, I believe, in the near future, or it did at the last meeting, which I missed. So I'm sorry about that. But so we broke up into really subject matter expert committees, and then for this committee specifically, we identified 3 areas that we wanted to work on and focus over the next 5 years. One was like drop-in recovery centers. One is recovery housing. And then one is just peer services in general. And right now where we're at in our strategic plan is we're focusing in on the recovery centers. And we've spent a lot of time and energy developing a broad definition of what a recovery center is. And we're fortunate to have the alcohol and drug policy staff that listen to us, work with us and guide us, and then do some of the what I would characterize sort of like administrative work that helps formulate our ideas into concrete written examples. And so with that, we're today talking about the recovery center definition. And Will, do you want to go ahead and lay that out for us?
Sure. And I kind of made some slides of how, what happened leading up to the end of last meeting, just so we all have a refresher.
Oh, thank you. Appreciate that.
We kind of covered a good amount of it. But I'll go ahead and do it anyway. Okay. All right, we good? Okay. So Tony mentioned the strategies that last year the recovery committee settled on, and those recovery community centers, recovery housing, peer services, recovery friendly workplace is kind of something we put off to the side for the time being. But like Tony said, we are focusing on recovery community centers and recovery spaces at this point. And a recovery space is, it's kind of like what it sounds like, maybe a space that offers some of the same services as a recovery community center, but for some reason might fall just outside that definition. So we want to talk about those as well. And one point is that they're actually not defined right now, like RCCs. So what I said could totally change. Um, so right, so expanding access to recovery community centers. So we had this baseline that, you know, we can't even count our RCCs right now because there's no definition. Um, and same for recovery spaces. So sort of the steps, the natural steps in this process kind of worked out to, in the first couple of years of this plan, and this is a 5-year plan starting this year. We want to define RCCs, also focusing on youth RCCs and recovery spaces, and try and figure out or pin down where these fit in the continuum of care. And then midterm, so maybe we think about that as 2 to 5 years, even though it's loose and not defined. Plan to expand RCCs and recovery spaces based on this work that we do in the first couple of years. And long term, a goal is to have at least one RCC or space operating in every county. And then increasing recovery capital, that's sort of what we're going for. So we have a work plan that's a little more detailed than what I just showed you. And so this is sort of our 2026 work plan. March this month, we will have completed a working definition of recovery community centers. That's what we'll talk about in a bit here. That's our goal anyway. Next month, 2 recovery representatives are going to present to Oregon Youth Addiction Alliance on what recovery centers look like for adults. In May, the committee will present to RCC leaders at the RCC Summit in Seaside, and we can get you more information on that if you'd like. And in the summer, we'll sort of finalize this definition of an RCC. Like today, after today, we want this like working definition. Then we go and get some feedback from some more people and bring that back and try and finalize this definition. And then also begin, sort of a product of that definition of an RCC is like the ability to talk more about a recovery space and what that looks like in line with a recovery community center. And then so we'll begin evaluating needs to sustain current capacity, as is one of our midterm goals that I just shared. Yeah, so just a quick note on recovery housing and peer services work plan for 2026. The ADPC staff, we will gather information on recovery housing, try and bring everything together, get it to a spot where we can say we need these people in a work group, and then establish that work group and sort of move on from there. And it's similar for peer services. Yeah.
Oh, thanks, Will.
You need, yep.
No, I was just saying, thanks for providing that overview.
Oh, yeah. For sure. And so I just brought this slide up because this is what prompted our discussion last time. And I just wanted to remind everyone how we got to where we're at. So we identified we need these recovery community centers. And last time we threw out these questions, well, why do we need a definition? Why is it a problem to not have a definition? What does it mean to have a definition? Maybe that's like, what do we do with the definition, right? What's the target population? Will it go into statute? Is this our recommendation, or is this what we use in recovery work around the state? Or does it just belong to the recovery committee? Where are RCCs in the continuum of care, and how do recovery spaces fit in? So there were 2 definitions we shared last time, just to sort of get some conversation going. And one of those is from the Recovery Research Institute. And so they focus on community-based recovery support, recovery capital, providing recovery information, resource mobilization, mutual help, peer support meetings, social activities, other community-based activities or services. And these centers will help facilitate these supportive relationships among people in recovery, including family members. That's a key. Lastly, they say RCCs may play a unique role that builds on professional services and connecting people to social services, employment, skill training, and educational agencies. So that was one definition of a recovery center from Recovery Research Institute. So there are many definitions. Another one is from SAMHSA. So RCCs are hubs of recovery support centered in the hearts of communities to help build recovery capital. Non-residential space for recovery support group meetings and recovery coaching, and linkages to employment training, other social activities. And they also provide space for and help facilitate like social community activities and engagement. So that's the second definition. We sort of combined those two definitions and tried to pull out key elements from those and had some help. Eric from MacBo did a little work around this too, and it was nice to be able to bounce some ideas as well. And so those key elements we pulled for like our definition last time were non-residential. At least this is what I shared last time for discussion. I'll let you look at those for a second. And I know some of you are on your phones, so let me read them actually. Non-residential, peer operated, usually a paid director, usually staff, volunteer opportunities, drop in, peer support, recovery coaching, host these mutual help meetings, development of advocacy skills for the client, resource navigation, social activities, connection to employment, education, and social services, the fostering of relationships for the client, and then just generally building recovery capital is what we thought fit into Recovery Community Center. And I pulled the feedback, some of the other big chunks of feedback from our discussion last time. And so generally people really liked those elements. And so, but there were some additional pieces of input I'd like to share again quick. A lot of these are sort of more centered around target audience, what sort of clients, visit recovery community centers. And we said is for those in a contemplative preparation state of change, these, like they understand they have an issue, they're weighing things out and getting ready to act. These clients would be people with substance use history who are engaging or want to engage in recovery process. There's some level of commitment to recovery. And this last bullet, we've done some reworking, but this is what came out of last meeting. Meet or met criteria for a substance use disorder, but remain open, but the RCC would remain open to those in remission. So someone threw out meet or have met in this regard. But we don't want an official diagnosis to be a barrier to the use of an RCC. Any questions up until this point? Just review. All right. So this is a definition that I drafted. And you know what? In anticipation of us making a few changes here, I'm going to stop sharing and bring up my, because that was my PDF. I'm going to bring up the PowerPoint so I can make some changes on the fly here. That's what we want to do. Okay. Let's see. Where we're at. Okay. And so this is the draft definition that I wrote based on all that information we just saw. So a recovery community center is non-residential, peer operated center, usually with a paid director and staff. Recovery Community Center offers drop-in hours, peer support, and recovery coaching. Clients are those seeking recovery who have obstacles consistent with a substance use disorder or who are in remission from such obstacles. And I used obstacles instead of the word symptoms and sort of acknowledge that, we need to not rule anyone out who hasn't had a formal diagnosis. A recovery community center helps a client build recovery capital by providing resources such as advocacy, education, volunteer opportunities, resource navigation, social activities, connection to unemployment. Sorry, employment. I guess it could go either way. Education and social services, fostering relationships, and hosting mutual help meetings. I'll highlight something here. I'm going to open this up for discussion 1 second. So there are a few ways that this second paragraph can go. A recovery community center helps a client build recovery capital by providing recovery resources, such as, and that such as is kind of key, because it sort of leaves it open-ended. So this definition would be more open-ended, like if a recovery center didn't meet connection to employment or fostering relationships, then they would still fit within this definition. But if we remove such as, let me see what it would look like here. A recovery center helps a client build recovery by providing resources. By providing, if this isn't making any sense, back me up. This requires all of those things in that second paragraph. And the things in the first paragraph are certainly required. So if that doesn't make any sense, just let me know. But I wanted to get that point across that to be very clear about which things are required and which things are more open-ended, if that makes sense.
Yeah, thanks, Will. Do committee members have any initial thoughts here?
I see Steph. I can call on people.
Yeah, please do. I got my phone close to my face so I can read.
Sounds good. Go for it, Steph.
Yeah, one of the things that really helps when we're looking at locations, access, and in various communities, if we do have the such as in there, then we have an opportunity for rural communities or even larger recovery community centers to open kind of like satellite locations in rural communities. And it makes it just, I think, a little bit more inclusive because it could be a very robust recovery community center, but maybe they don't have volunteer opportunities because they don't have the staff necessary to like oversee and coordinate that. Or maybe they have volunteer opportunities, but they don't have like maybe they're missing an opportunity to have social activities. So I think if we could, there definitely needs to be more than just one component, but I think we also want to be really inclusive if we're trying to stand up recovery community centers across the state. I do think that there might be some communities that don't have the resources necessary to incorporate all of that.
Yeah,
Great.
thanks, Stephanie.
Now I see John.
Yeah, similar comment. Just I think when we form a definition, it should be something that's reachable. And if we, make something that's so strict or has so many components that it's not reachable, we're gonna limit places and communities from having centers that at least follow this definition.
Thanks, John. Todd?
My comment is similar to the last one in that I think the language of such as is important because it would help recovery community centers scale up so they could start small and then build on that because as everyone knows, it's pretty hard to build a comprehensive system from the get-go.
So I threw a question in the chat after Steph's comment. It's kind of to all three of you. Should it be at least one that like they're doing at least one thing, or is such as better?
I think it should be more than one thing, but not so such as might be better.
Yeah, is there a few minimum things that we think a recovery center should have, and then additional things that would could bolster it? So, I'm thinking like the social activities could be a critical thing to a recovery community center. Um, Resource navigation could be pretty critical, right? If people are coming in, they're getting the couple basic things, and then having some additional um, programming could be sort of either there's capacity to do it, or an organization wants to bolster for a couple of, to do a couple more service types.
I was on mute. Stephanie Sloan.
I was thinking the same thing, like if there was like a baseline requirement to meet, because that would be important. But like just even thinking of like the different communities, like everyone might have a different need that's really heavy that they have to focus on in that particular area or time and space. But like having that baseline of like, this is for sure this is what you're gonna find, and then there's other opportunities too, is where my mind was going.
Okay, thank you. Todd.
Yeah, my question would be, I think it depends on how we use the definition. So if somebody's putting in a request for proposal or, that kind of thing for funding, then that's where, whoever's reading that could make sure there's at least one of those. So it'd be more like in the rules than in the definition. So that's just kind of hopefully that makes sense. That's a question I have.
That does. Thanks, Todd. And I think we're gonna get there next, but I'm realizing like how much these overlap too. So I really appreciate you bringing that into this discussion. Steph Cameron.
Yeah, I was gonna, somebody or a couple of different people had already mentioned it, but I do think that we do have to have like a baseline, and it does need to be more than one. I just was kind of reflecting here, and I know that we don't have a state like certification for recovery community centers, but having a really strong definition with kind of the baseline is going to help us if we finally get there, which I sincerely hope we do. And there was something else that I was going to mention. I had my hand raised because I was thinking hosting mutual help meetings. And the reason I put it down is because that is such a great goal. But when you start looking at locations and space, sometimes it can get really harder to have that one be like one of the main foundational requirements. Or at least that was our experience.
Great, thank you. And just so the way I kind of wrote this and was looking at it was the baseline was kind of fitting into that first paragraph, and then the other stuff was more the such as stuff was the second paragraph that we hadn't really hashed out yet. So I was like, okay, the baseline, it's non-residential, peer operated, usually with, paid director and staff, drop-in hours, peer support, and recovery coaching. So I think like the baseline, the requirements that we want for an RCC can go into that first paragraph, and additional can be this second paragraph. I bolded two things that it sounded like might be candidates for the second paragraph, and that was volunteer opportunities and hosting mutual help meetings. Like the lack of either of those, it would not exclude someone from being an RCC. Some organization from being an RCC.
Yeah, well, just to go up to the first paragraph, a couple things here. So, peer support and recovery coaching, those are like the same thing. They're just two different terms that are used nationally. So it the third thing in the first paragraph could be social recovery support or something like that. Recovery support services, which are not connected to clients. And then in here, we're using the term clients, right? But not everyone who comes to a drop-in center is a client in the way that it's generally defined in the substance use sector or healthcare sector.
Right.
And so, participants might be a better term to use to know that not everyone who come, has to be a client. People might just drop in, hit a meeting or a skill development activity or an advocacy training or something, but they're not like a client. They don't get informed consent, they're not having documentation on them, etc.
Okay, thank you. And so like part of this, there's a next step to this definition. Depending where it goes, or I mean, it's sort of a necessary step is defining the things within the definition, right? And that's something we're gonna have to work on. I know, like when we say something like when I wrote clients, I was kind of thinking that, but it just didn't have the word, which, I think that's going to happen kind of in different places here. And like recovery support services, right? What does that mean? Like if this were to be a definition that was adopted by state agencies or when it, statute, um, the specificity of some of these things, we'll need to address that, sure. So Tony, do you have any thoughts?
No, I think we're still getting at the intent right now of what we're trying to say, but then there's some sort of legal regulatory filters that it's going to need to go through to meet the intent, is what you're saying. And okay.
Yeah, and I think the first priority is the recovery committee, establishing a definition that they're comfortable with that, rightfully describes a recovery community center, and before moving on to how that will need to be altered.
Well, there's a couple of comments in the chat.
Cannot see those.
Do you want me to read them, or do you want to read them?
It would be great if you could read them, yeah.
Dorothy, who I think is a member of the public. Welcome, Dorothy. What about access to urgent services in the case of a relapse or potential relapse? Connection with a crisis counselor for mental health. Is any of this applicable for these things? As a CADC3 and LPC, in my experience, this is important to have. And then Amanda commented, I agree, there needs to be a baseline or minimum of services. I think resource navigation, connection to community partners, and social activities and services are things we all do that are essential to the recovery centers. And this made me wonder if instead of recovery support services, should that maybe be more social? Tony, you said it differently the first time, and I can't remember what you said, but is it more like
it's like social recovery support?
Social recovery
support.
But
then I was like, in my mind, I was trying to pull together a common term that's already used, which recovery support services generally kind of represents a social supports, peer services, etc. And so that's why I said that. But I think the intent is social access, right? That's the main benefit of the recovery centers, is the community social recovery model is really what separates them from treatment. Not that treatment's bad, but treatment's cognitive model, right? Clinical model. And so I think social supports is fine. However, we need to articulate that to get it through, if we go legislative concept or rule, to make sure that we don't shoot ourselves in the foot is important. And then just to comment really quickly from Dorothy, great question. We recognize generally the need for that to happen when it occurs, and that's the resource navigation and connection to other service providers in the community is really critical to support people. So that's naturally something that'll come with the resource navigation. Okay, well, let me ask everybody a question here. Knowing we got Will that's going to run this through some filters, capture our intent, do we feel like we've got generally a framework for a definition, knowing that it may need some wordsmithing?
What would help for me is if we could try and sort out some of these services in the second paragraph into the ones we want to move to the first paragraph.
Okay, well, let me see if this will work. Sounds like people were cool with the such as in the second paragraph. Hey, here's all the things, but we wanted some baseline. Do people feel like the first paragraph covers the baseline, where the second paragraph can be the such as with those other elements? Okay, Amanda says yes.
Yeah, Tony, I think yes. And Will, I think that when you say recovery support services, social supports, I mean, I think that's really what we're talking about down below. You just get a little more descriptive down below, but I think, we would not be doing a service to make it so narrow in the requirement, to limit folks from opening or operating.
Yeah, totally agree. Stephanie, go ahead.
I really love the way, like, now that we have the recovery and social supports both, like, it would be great if we could kind of combine those, like recovery and social support services, because sometimes people are coming to us and it is resource navigation. But sometimes they are coming to us because we're the place that they feel most comfortable looking for clinical services and navigating them to clinical services. And I think like that is such a part of the continuum, like getting somebody into clinical services and making sure that they're stable. And then we pick it back up. And I know I said that in the last meeting when we were talking about that, but now that it's like both there bolded, I just think it looks so nice together.
While you're pondering, Will, and collecting information, David Simmons in the chat said, yeah, SAMHSA tip 64 may be of support, and diving a little bit into the definition of recovery support services to basically attempt to ensure the consistency in language that we're using. So thank you, David. And Todd, I want to circle back around to you and make sure we have captured your intent and it's moving the right direction.
Yes, I would say so.
Okay. And Will, do you have anything more that you need from us to move forward?
I think we can move forward and to the next agenda item, and yeah, after that we can touch base on what we just did again. I think it's
Sure,
great.
and then come back and
Yeah.
what's our date to vote? May? Is that right?
We haven't
Or-
really. Yeah, that's the
Okay.
goal. Yes.
Yeah.
Is
So
it
goals.
May or is it summer? Why did I have it in my head? It was summer.
I have it in the slides as May. Let's revisit that. I think it'll play out in May. I see Frank has his hand up.
Yeah. Hey, Will, this is Frank. If you need any support or help with this wordsmithing or whatever, I'm happy to give you a hand.
Great. Thanks. Appreciate it.
Thanks, Frank.
All right. So now Tony, I don't know if you're looking at the slides, but what do we do with this definition?
So before you get in that, so just looking at a high level, what we're trying to accomplish with the ADPC, right? We want, we've identified that we want recovery centers to be a part of the continuum of care. And in order for that to happen in the most effective way, we got to define them so that state agencies and funders know what to fund, right? Like they know what to fund. And, we have some decisions to make about what we do and how we do it moving forward. And I've heard, regulation. I've heard, legislative concept. I've heard accreditation. And it's something that we're going to need to sort of weigh the pros and cons of all those things moving forward, because sometimes there is unintentional consequences when you put something into statute and regulation rolls out. And sometimes it's really, really good. And sometimes it's not so good because, state agencies and stuff, they have a requirement to the public with public funds, and, their responsibility can come into play. And sometimes there's tension between what providers want and expect and what the state wants and expects based on their roles, responsibilities, and interests. So at the very minimum, the Alcohol Drug Policy Commission can issue a definition and guidance, and then at the very maximum, we can say they need, we recommend that they are licensed, entities. So I just want to say, we want to be thoughtful about how we move forward with it, moving forward. And is there anything you wanted to add, Will, in addition to that?
That was good. Thanks, Tony.
I mean, I'll step in and offer an example of kind of like the minimum next step, if it's helpful for people to think about it. I think as most people in this room know, state opioid settlement funding and local opioid settlement funding has gone to recovery centers. So like that's a known funding source. I think the settlement board would be really happy to hear that, you all developed a definition, and if they're going to invest money in it, we would really hope that it meets this definition, like absolute minimum, just for people to kind of think about. As Tony said, there's, the next step, do we want to put this into state law, knowing that if we do that, it might be a dance with some of our state agency partners who feel like then they need to inspect them and respond to complaints, and right, like that, all the way to that end of regulation. So just thinking about next steps. And again, we don't have to answer this today, but it's helpful for us to think about in setting the next steps up for the rest of the year.
And I know we have different subject matter expertise in this room that have run recovery centers, but who's also worked in treatment and licensed facilities, Department of Education, and so I'd love to get some insight from people around the pros and cons of regulation. Maybe we start with some of the pros. What are some of the good things that happen out of regulation? And we can get into some of the problems that we experience as a result of regulation. And Billy, hear from the public, but I'll let you weigh in. We usually reserve to the end for public comment, but it's cool to go ahead and chime in.
Oh, my fault. I thought you were kind of opening it up.
No, you're totally fine.
No, I was just saying the good thing on regulation is making sure that there's not, bad players, as we've seen elsewhere in the country, that come in and just kind of go wild with grabbing funding and not doing the right things.
Cool. Thanks, Billy. Todd?
Yeah, I was going to say the same thing. And additionally, it's where you can establish minimum standards.
Yep. Okay. Frank, you work for the government right now. What are some of the benefits of regulations?
Do you know something I don't know, Tony?
No, but what I mean, as a county worker, like, would love to just have the county kind of perspective, also your personal perspective. But yeah, just like some of the things that county might look as a pro to having this definition, and I'm giving you some signals of what to do, maybe.
You bet. I think one of the key features of the whole regulation thing, in my view, is that it sets out, what outcomes we expect. And then maybe, if we're lucky, sets up a process by which those outcomes can be measured. And I think that's a real helpful aspect of regulation, and always looking for ways to, collect data, particularly on, a process that has not had a ton of data collection around it. So that's one thing I would say for sure.
Yeah, and I would double down on that, and say, hey, it can provide validity to what the funding's going towards. Hey, this is a legitimate thing that's happening. Here's the parameters of what the public funding's going towards. Here's why it's important, and it allows for both scalability and sustainability. The more valid it is,
Absolutely.
Okay. What are the downsides? What are the potential pitfalls?
I think we can find ourselves backed into a corner with some regulations because of the type of services we provide and the way that we provide them and how they differ from clinical services and the really rigid, all of the rigidity. I also wanted to say one of the things that I think is a pro is the legitimacy. The peer programs and recovery services delivered by peers, we have fought really, really hard to be recognized as a legitimate service in the care continuum. And so I think this is another opportunity as a pro to just provide more, evidence that what we're doing has benchmarks and that we're meeting them. And then, because clinical services and kind of the standards of clinical services and the way that clinical services have been delivered for decades, I think that if we get too close to regulations that are asking us to mimic those type of services, then we've just kind of washed out everything that we worked so hard for.
I would say that one of the challenges is that oftentimes we're trying to measure things that are very difficult to measure, or measure things that are not measurable. How do you measure something that didn't happen? And that's kind of what prevention and intervention are about. So that's one of the downsides, but there's also that, fiscal responsibility piece as well. So that's one of the challenges.
Yeah, one of my big worries is like the unintended financial impacts to the programs through licensing standards, um, administrative burdens. That's one that also impacts finances, and then qualifications around sites. You know, uh, certain qualificate like you know this, and a lot of that stuff already happens sort of in the zoning and usage and stuff, and uh adherence to fire regulations and stuff like that. But there can be additional requirements imposed on sort of the dimensions of the program, how big it has to be, separation between spaces for confidentiality, right? Some of that stuff could impact the ability to have the social aspect there if there was over regulation on the recovery centers. Annalise, I see you kind of pondering there.
Multitasking.
Oh, okay. So, oh, okay. So it's just something to consider, moving forward, and how we roll this out. The other thing is, the grassroots organizers outside of this meeting, can accelerate things that happen or respond to legislative priorities that are unknown at this time to this group. So we can be specific in the definition and prepared for regulatory implementation, even if we're not sort of pushing that right away. Like Oregon Recovers, for example, has pushed recovery center bills trying to get them funded, right? And right now there is scarcity in the system about what's going to get funded, right? And so advocates are going to be looking at, how do I maintain programming moving into next year, and may accelerate funds towards more recovery centers or sustaining what they have, or programs might be on the chopping block. There's like a lot of unknowns moving forward, and a lot of things that can happen. So guess what I'm saying is, we may want to be prepared for multiple things, but as far as this group goes at the ADPC, what do we want to happen moving forward, and what is our timeline? And we don't have to answer that all today. We just wanted to have a general discussion. So, order of operations here for us sounds like Will has enough for the intent of what we're trying to accomplish. We have a couple more sort of quality assurance steps to take to make sure we get the right language. It's consistent with, national standards. If our definition does move to a regulatory process, there's not any unintended consequences. We're going to take this definition, and then we're going to vet it by as many recovery center operators as we can. Not everybody in this meeting is a recovery center operator. We do want to get that buy-in from the community, something similar that we'll do later on with recovery housing, as Will prefaced. Then we'll come back and hopefully vote, get it approved. And as that process is going on, we can consider weighing our options on next steps to implement it. That sound about right, Annalise? Will? Perfect.
Good.
Okay. And is our other presenters here?
I do believe I saw Charmalie, yes. And so the recovery committee, throughout our comprehensive plan work, we've identified partners to help us, to work with on a lot of the strategies that we settled on. And this year, as we're coming into the 2026-2027 work plan, we've identified partners we're going to be working more closely with. And one of those is OHA's Office of Recovery and Resilience. And we have not had Recovery and Resilience present at one of our meetings. And I thought it would be, or we thought it would be great if we could hear a little bit about Office of Recovery and Resilience and how it may be tied to our strategies like the recovery community centers and peer services and housing and stuff like that. So, Charmalie, you ready to talk?
Yeah, before we pass it off, I just want to say, Sharm, Will, Walter, thanks so much for the work you do. Will, you're doing awesome leading all of us. But Sharm and Walter, they're from Recovery and Resilience. They've done a ton of stuff over the last few years to build the infrastructure of peer services, recovery services, have partnered to launch a ton of initiatives and activities to increase the visibility of peer services, the validity of it, the competence within the peer workforce. I've helped out with recovery housing initiatives. So they've been doing a lot of work inside the bureaucracy of OHA and really advocating for peers around policy practices. And so I just wanted to get you guys a thank you and a shout out in case everyone doesn't know. I have a meeting I got to bounce to, but thank you so much for coming. And thanks for everybody for attending today.
Thanks, Tony.
Thanks, Tony.
Yeah, hi everyone. First of all, I just want to say I had a really great presentation for all of you ready. And then some things happened with my leadership and I was unable to get it approved because we have a process for doing that anytime we share a presentation with community. So I'm just going to be talking at you and also want to say that I feel like I'm coming down with the flu, I just realized. So I hope you give me a little bit of grace. My mind's a little foggy and I'm not feeling well, but I'm really, really glad to be here and be chatting with you all. So first of all, my name is Sharmali Nataraja. I use she, her pronouns. I am a person with lived experience of behavioral health challenges, struggled with substance use disorder for many, many years before finding recovery in 2019. During that time, also encountered our criminal legal system because I couldn't stop using substances, so have lived experience with that, and also living experience with mental health challenges because those started popping up once I stopped using the drugs. So I'm also a peer. Want to mention that I'm a peer support specialist. I had peers myself at many different points in my journey before finding recovery when I was actively using, and then at the very end of my using journey when I found recovery, then I had recovery peers. And then I had the opportunity to work as a peer, mostly doing harm reduction work and to give back what I was given. So peer work is very near and dear to my heart, as is everything to do with recovery. I'm going to pass it over to my colleague Walter real quick to introduce himself because I see Walter here.
Hi, everybody. My name is Walter Bailey. I represent the Office of Recovery and Resilience. Gosh, so grateful to be here. I was blown away with a lot of the things that I'm hearing with what kind of work you guys are doing is very aligned with my goals. And I hope I can, continue to walk alongside you all as you're doing this work. I'm a person with I shouldn't say long-term recovery. I'm a person in recovery. I am a peer, centrally located in Portland, a person that has sports in my background, a person that became homeless because of addiction. a person that has experienced mental health challenges, but overcoming that on a daily basis, being able to be a part of programs, going through a program treatment, DePaul Treatment Center, and then now, or not now, but that back then, after 2 years, started working there and then transitioned to Central City. And then now my professional career has taken me to OHA. And a lot of you on here that I do know from here and probably in the community. The last thing that I'll say is recovery is probably one of the most important. It is the most important thing in my life. And what I have not been able to do is find more opportunity to dive in with the folks such as you, such as all of you. So I'm excited for the opportunity. I don't know what that means yet, but whatever I can do to support, I'm here for it. And I just want to continue to hear where you guys are and in the process of what you're doing, and whatever I can help with, I will do my best. So that's me. Thanks.
Thank
Allow
you,
me.
Walter.
Yeah.
So the Office of Recovery and Resilience, we're also known as the ORR. We're a lived experience office at OHA, so that's what makes us different, first of all. In other programs and teams at OHA, sometimes they have some individuals with lived experience, but that's a requirement of our office to work in the ORR. So some of us have lived experience with substance use challenges, mental health, some with the family experience of behavioral health. We're all trained as peers. Many of us worked as peers before coming on board. I mentioned previously that I did. Walter worked as a CADC before joining the ORR. So all have experiences working in different aspects of behavioral health. I'm putting in the chat our recovery vision because I feel like it is very aligned to the purpose of the ADPC Recovery Committee and what you are all doing. I'll read that really quick. Recovery is not a dream, it is wholly attainable, and it is the expected outcome of a system that fully responds to the needs and directives of those it serves. Self-determination is a core element of recovery. When people direct their treatment, they direct a critical part of their lives. A chief goal of our office is to be a cornerstone for systemic change and reshaping policies and service delivery towards a recovery-oriented system of care. And we also strive for services to be more welcoming and to fully honor each individual's dignity. So that's our recovery vision. Really, our office, we do a lot of things, but two main things. One is elevating the voice of lived experience to policy and systems at the state level. So ensuring that people who are accessing behavioral health services or might need to have voice and choice in the services we're creating. The other thing is everything to do with the peer workforce across Oregon. So enhancing the capacity and longevity of the peer delivered services workforce. Let's see. So one of our main programs I'll mention is called Peer Respite. For those of you that haven't heard of Peer Respite, in 2021, House Bill 2980 was passed that funded this program. Respites are similar to like a crisis home, except they're only staffed by peers. So for up to 2 weeks, individuals can self-refer if they're in any type of mental health crisis. That can be a person experiencing or who has been diagnosed with a mental illness or self-perceived emotional distress, retriggering of trauma, whatever it is. They can refer themselves to these respites and stay in a home-like environment for up to 2 weeks and receive 24/7 peer support and linkage to resources and ongoing services. So that's something that's been done on the East Coast for a while. That's why we brought the model over to Oregon, and it's been hugely successful so far. Just being able to divert people from hospital systems and jail systems, the cost savings there, and then just the person-centered way of approaching a person in crisis has been really, really incredible. So there are 2 respites currently operating. One is in the Portland metro area, one is in Depot Bay. And also want to mention that peer respites are in statute always staffed by, or ran, excuse me, by peer-run organizations. So that's something important to remember or to mention, because in that program, like so in statute, when my team wrote out the peer respite statute and rules, we defined peer-run organization for the first time. So that was a huge win for us and for the workforce overall, because by defining peer-run organization, we've been able to make specific investments into peer-run organizations. And so that's looked like being able to do requests for grant applications or RFGAs, requests for proposals or RFPs, requests for information, RFIs, with peer-run organization status either being a requirement for funding or sometimes being a part of the scoring rubrics so that they receive priority status in the awarding of funds. Some examples of that are, of course, the Peer Respite RFP we put out in 2022, and then also the Recovery Drop-in Center RFI that you all were involved in, this Recovery ADPC committee. So as far as peer-run organizations, my team, we work with all sorts of, really anywhere in the system where a peer is, embedded, or, all areas of the system where peers are. But we definitely have a focus on peer-run organizations and supporting them. I do want to mention that equity in peer-run organization investment is a value of my team, and especially geographic equity. And so it's been amazing that we have peer-run organization defined and that we're able to have specific investments going towards, organizations that are ran by people with lived experience. However, as a system, we have to keep in mind that there are areas of Oregon, such as our rural and remote communities, in which we do not really have peer-run organizations. And in some areas, we don't have any. So just as a system, really keeping in mind that we need to build up new peer-run organizations as we are putting out funding that prioritizes. What's next? Okay, so peer program services, yes, Dorothy, I see that in the chat and I hear you. So we have peer program coordinators on the team. One is our family services, family peer services. So I'm just going to define what a family support specialist is really quick, because there are still many areas of our system who don't understand that we have an entire peer support worker type that is for families. So a family support specialist, or an FSS, is a parent with lived and living experience navigating child serving systems on behalf of their children and or youth who need behavioral health, mental health, or other health supports. So an FSS they can be either a PWS, a peer wellness specialist, or a peer support specialist. So we have a position on our team that supports that workforce and works to meaningfully embed FSS in a variety of behavioral health programs within the child and family continuum. So examples of that are mobile response and stabilization services, or MRSS. That's a component of mobile crisis. Also things like intensive in-home behavioral health treatment, or IABHT. And then a big part of their role is elevating the family voice into systems and policy. Another program of ORR is forensic peer services. So that looks like collaboration with MACBO, our Mental Health and Addiction Certification Board of Oregon, on forensic peer best practices, trainings, and the endorsement that was created last year. Also working to create a pathway for forensic peer endorsement through the traditional health worker program. That position maintains relationships with a diverse group of court system and criminal legal system partners, such as Oregon Department of Corrections, or Oregon State Hospital, forensic diversion teams, reentry peer organizations, etc. And then, excuse me, a big part of that role is really looking at the intersection of mental health and our criminal legal system. And so supporting the inclusion of peers into forensic mental health systems, such as civil commitment and aid and assist, and et cetera. Community engagement is a big part of what the ORR does, one of the biggest parts. And that is with not only peer-run organizations, but as I said before, just really anywhere where peers are in the system. So also peers embedded in clinical programs, other systems partners such as our, Department of Corrections, our hospital systems, our CCOs, our CMHPs, and et cetera. Also engaging consistently with current and former recipients of behavioral health services. And then just people with lived and living experience, sometimes who have not accessed behavioral health services due to a variety of reasons, sometimes to deal with, equity, like not having access to a provider that looks like you, or being in a rural area where you don't have access in general to providers. I want to mention that engaging with rural and remote communities is a big focus of our office. We have another community engagement analyst. His name's John Parsons, or JP. He's like my counterpart, where I'm focused on Portland Metro and youth systems. And then JP is really focused on rural and remote areas of Oregon. And one of the values in our office is to get out and meet people face to face as much as we can. It can't happen all the time, but we do that as much as we can, to show that we value and respect the perspective of these individuals and organizations. And especially when it comes to rural and remote communities, that just makes such a difference. Showing up in person, seeing them face to face, hearing about the barriers, hearing about what they need. So JP does a really great job of traveling across Oregon to connect with all sorts of rural peer organizations. And then we also have a focus on connecting with culturally specific peer-run organizations in our office. And Walter, I don't know if you want to say a few words about your work with that, because Walter's the one who does that.
Sure. Thanks, Sharm. Yeah, with culturally specific and kind of my subject matter expertise, I think for our office for the last, I would say 2.5 years, one of the beauties were a grant, or actually a funding opportunity that we were able to put together from the Office of Recovery and Resilience. And we were able to add, I think it was out of House Bill 4071, in this actual funding process, we were able to add a equity lens, and we really helped communities and different organizations that probably never would have had the opportunity to be funded by OHA just because of all these different reasons. And I had a lot of pride in that. Our team, we just we grinded, and we were able to look at the benefit of how many other people that don't get these opportunities that are doing great work in the communities. When I look at what's going on now in the country, we have culturally specific and linguistically appropriate organizations that are having to close their doors. Yes, there's no funding. And also right now, how are we encouraging other organizations, how they can try to come together and stay afloat with what's going on? And so for me, what I try to do is I like to try to show up to organizations when I can, but it's not just what they need, but it's kind of like the support to foster that relationship, but uplift them, right? And the differences of it's not just one size fits all. Everybody has what they do as their niche and how they do it. And so for me, it's the work is different. The work is hard sometimes. As a small team, we support each other. It's difficult trying to get other leadership support because they're doing the best they can, but we try to hold them accountable too. When we look at, like Sherm was saying, about rural counties and frontier counties, right? Like, how are we being able to support, even from the Portland metro area? Right now, I think we're doing some cross collaboration of support because right now, I mean, that's what we need. We got to support each other. So for me, it's just kind of realizing with how I get to navigate every day when I'm not being able to go out in community. There has been some limitations for us with travel, but I still go anyway because I have the care in my heart. So there's some organizations and folks that are here. We got to travel down to uh, to to uh, to the coast to Coos Bay. That was awesome to go visit Bath. So for me, like I said, it's really important the culturally specific folks that I have. The last thing that I'll say is some of the barriers from the immigrant refugee populations and organizations is that we just don't get to them, and they're doing great work. So sometimes with limited roles or just only having one or two people, we can't cover the whole diaspora of culture, but we try to do our best. So I'm always open for suggestions for anybody that's here that you know of organizations that are peer ran or has peers. Please let us know. We like to follow up and meet them and integrate. Yeah, so that's it.
Thanks, Walter. Next thing, one of the biggest things that the ORR does, and definitely my biggest role, is serving as peer subject matter experts for the state or for OHA. And so we support the inclusion of peers in all areas of the behavioral health continuum of care. And what that looks like is really anytime that programs are being developed that have a peer component, we're being looped in to provide feedback, make sure that it's done right, make sure if there's new programs that they're being developed with fidelity. And so providing technical assistance to definitely OHA teams on the provision of peer services and also to outside peer organizations sometimes. And yeah. Next thing is legislative bill analysis. So as OHA staff, we're assigned bills every year. We just got done with short session in 2026. And really any bill that has to do with peers or recovery or community engagement comes to our team. And then sometimes like specialized ones depending on the position. So like forensic stuff, civil commitment, anything to do with, the criminal legal system goes to the forensic peer, family stuff goes to the family peer, and whatnot. But in general, peer stuff, recovery stuff goes to our office, and we're one of the people who have eyes on those things. Also, participation in rule writing. So when rules are being revised that have a peer component, also being looped in, and then leading some of our own rule writing processes. Lastly, contract administration for the peer workforce. So our team has a variety of contracts for peer delivered services, from direct services to other things that enhance the capacity of the workforce. So training provision, continuing education, technical assistance, and all of the things. So yeah, I guess I will end with some of the things that I'm currently working on that to see if there's any intersections in what you all are doing. So my position now is really focused on peer systems work overall. So streamlining the system, figuring out what the gaps are, what the barriers are to make the workforce function better. So one thing is I'm in the process of figuring out how to develop trainings for non-peer peer systems partners. So, all the other members of multidisciplinary teams, our hospital systems, the CCOs, CMHPs, our criminal legal system, everyone who works with and around peers who sometimes do not understand the peer role. And because they don't understand their role, they don't know how to effectively integrate peers into their team. And then that's when peers are harmed. And the people we serve are harmed as well. So that's one thing. Also looking at rule revision processes around peer supervision, and then been in talks recently about all the issues with certificates of approval for peer-run organizations. I'm about to connect with someone that's in this meeting today about that pretty soon here, and I've been talking with other OHA teams about how to address that. So those are some of the systems things. And then, as Walter said before, the work you all do is so aligned with our office and the values of our office. And so any way that we can be of a support, I'll mention that as far as the peer systems education trainings, the hope is to have trainings for each type of peer worker type. So recovery peer would be one of them. Trainings are really explaining like what recovery peers do, how they differ from like a mental health peer. Also breaking down differences between certification boards and all the confusion around that, just all the things. And when that process starts really ramping up, would love feedback from you all or some way of just being able to hear your valuable knowledge and expertise in that area. So yeah, I think I've talked enough at you, and I will stop there.
Thanks so much. Before we get into public comment, any comments or questions? Steph, go ahead.
Hi, Sharmali. Hi, Walter. You actually look very familiar. I think I may have seen you in little rectangle type boxes in 2022 and 2023. I don't know if I'm right or wrong, but it's great to see your face again. Sharmali, thank you so much. Sitting here in this meeting right now, I just realized how much I missed a different networking meeting that you and I used to visit a lot. And so there used to be a peer ran organization networking meeting that has stopped for whatever reason, for those who did not know that was in existence. I mean, it was so great too, because we had opportunities to talk with the Office of Recovery and Resiliency, like directly. And so shameless plug, if we can get those back, that would be so amazing, because it was just so beneficial to learn on a regular basis what was going on in your office specifically. There was a couple things that came up. I've heard about peer respite houses, but one thing I haven't heard a lot about is like peer respite houses for individuals who are trying to navigate like clinical care for substance use. One of the things that we experience a lot here in Eugene is that somebody came out of detox or something like that. They're not quite ready for that next step into a recovery house because of the requirements that recovery houses have, but they don't have anywhere to go, and they just really need somewhere that is safe and can provide those wrap services, because they've been medically cleared, but they're not ready to integrate into a communal living situation, and either it's not safe for them to go home because of the environment, or or there's just so many different factors. Another thing that happens sometimes is a natural process, and the recovery, journey sometimes can be a return to use, even with the supports of a recovery house. And we see a lot of people really end up in some pretty dire situations because there isn't a place for them to go to get back on track, to reestablish, to be safe, to be recovery focused. And so when I was listening to you speak, and when I found out that recovery or peer respite houses fall underneath peer ran organizations, I'd really love to explore what that might look like for Lane County. And I also have some pretty passionate staff who are trying to, encourage me to find a solution. So I would love to talk more about that. And then also,
Sorry to get in stuff. We have to get to public comment.
I'll connect with you.
Cool. And thanks, Sharm, for joining us. And likewise, if the recovery committee can be of help to you as well, please just let us know.
Sounds good.
And with that, any public comment?
I have to say that I really enjoyed this meeting. There's lots of information. I will probably have more comments later, working from a substance use and mental health provider. I've been a provider for many years in the community until I came to OIA, and we need a lot of these services. But yes, it's the red tape of jumping through some of these clinical hoops with the person, the peer that just wants to help because they have walked through it and they know that personal touch would help. But then there's legality. So anyway, not a particular comment now, but I thoroughly enjoyed this and I thank you all.
Thanks for joining us. Anyone else? All right. Well, with that, thanks so much, everyone, for your work today. And I'll be in touch with, the definitional type stuff and see you again next month.